right. Well, good evening, everybody. First, congratulations. A big applause for all of you because you chose the right meeting to come to. So here you go. Thank you. Thank you. Thanks. Thanks. It's a great honor and delight to really work with you all today. This is going to be quite interactive. Again, we're going to talk about the accelerating innovation in biliary tract cancer and restructuring the treatment models for immunotherapy and targeted platforms in advanced disease. We will be delighted to welcome our panelists. My name is Abou-Alfa. I'm from Memorial Sloan Kettering Cancer Center, New York. And join me today or tonight is Dr. Lipika Goyal, and Dr. James Harding, and Dr. Vogel. I'll make sure I introduce all our wonderful colleagues as we carry on through the program when they come to their parts. And with this, please remember that we have a great thanks here for the American Association for Nurse Practitioners, peer review, and very importantly, for the Cholangiocarcinoma Foundation, who is joining us tonight for providing this session with support that we got from many companies, many of the pharmaceutical industry colleagues from AstraZeneca, Insight, Jazz, Taiho, for supporting this educational activity. Please look out. There will be a lot of polling during the presentation, and would love to hear your input as well. And please submit questions, and we will be definitely happy to discuss many of them at the end with the Q&A at the end, and I will be seeing them here on the screen as well. There's a lot of devices that you will see on the QR codes, and you can scan this now, so you can really be able to open the app and add the questions. And one more thing here. Now, please pay attention. Any of you who submit at least 2 questions, of course, you have to remember, they have to be good questions, okay, guys? We have a special committee for this that will review this. It's not like, how are you doing, or it's really nice today. So it has to be a good question related to the matter. And any of you who submit most questions, I said the minimum of 2 to be eligible for that. But if you submit the most questions, we don't necessarily have to answer them. It's not like, but they have to be good, valid questions. The highest number of questions will get an Amazon card, a gift card from PeerView. So stay tuned, and let's see who's going to win. And we'll announce the winner today at the end of the program. So keep it clicking, keep it going. Great. And with this also, please remember that you can visit the website for PeerView, peerview.com/biliary-San Francisco 25, SF25, and you'll view the slides and practice aids that will be helpful for you to download as well. So this is a great tool and a great component that will help you as we go on. Actually, will help us a lot ourselves as well. And our goals today is to summarize the importance of biomarker testing. We're going to talk quite a bit about that, current safety and efficacy in regard to evidence of immunotherapy and target platforms, and update in regard to the guidelines for biliary tract cancer. We'll try to develop a tailored treatment plan for systemic options of therapy for biliary tract cancer while looking at the molecular findings and clinical trials evidence and practice guidelines. And of course, very important to formulate a team-based approach in regard to that disease in biliary tract cancer, while of course working on the education, shared decision-making, treatment-specific dosing and scheduling, and of course adverse events impairments. And with this, we would like to start by giving you some reference to the whole story over here. As I mentioned, my name is Abou-Alfa from Memorial Sloan Kettering Cancer Center, New York. And I'm definitely, by the way, delighted and thrilled about the heat wave we're getting here in San Francisco compared to New York City. And we'll address the healthcare gaps with model strategies. And this is a beautiful work which I recommend that you look at from our colleague, Dr. Bill Javli, that really can see, and I think this does not need much of a conclusion from any of us, but you can see, sadly, that there's a rise in regard to the incidence of the biliary tract cancer, specifically cholangiocarcinoma over here. And sadly, the death rate is not really kind of like faltering apart from where we are. And you can see that some variation in regard to the different diagnoses, but intrahepatic cholangiocarcinoma still stand out in regard to really have the worst outcome. And maybe extrahepatic might be a little bit of better apart, but nonetheless, they are still fall within really a very important, what we call, all of us by default, unmet need in regard to need for further therapy, which we'll discuss today. And with this, you can see here how patients transition. This is very important. This is really what happened in all our clinics, and I'm sure you probably all agree. In first line, we kind of like do rather okay, but not perfectly okay, because interestingly, the tool to try to get genetic testing and next-generation sequencing testing is still faltering, because we can start patients on chemotherapy-based treatment, and at the same time, we can evolve to a second line, but this is where things start faltering apart. And you can see in second line, we can really have less than half, 46% of patients only get to second line therapy, despite there are options, as you can see here. And especially look at those kind of like wave trends. You can see how it starts thinning out, and specifically look at the one in yellow of the targeted therapy and see how thin it is. It's definitely make us really wonder and kind of pause, especially when you come even further to the third line therapy, which in a way is good. They're talking about third line, means people are alive and they're able to get therapy, but at the same time you see how thin we are in regard to the options, even though they are probably available as well. And in the big scale of things, we are really concerned that clearly less than 30% of the adult patients are offered clinical trials, specifically here in colorectal carcinoma, but really it's kind of commensurate with what we see in regard to other diseases. Sadly, still, the adult population don't do as good as pediatric population got to clinical trials, but this really tells us how much we're still behind. Number two, enrollment is always challenged. Understandably, this is a very complex disease. It took us a while to really understand even the dissection of the different, anatomical variation add to the biologic variation per se. And if anything, access to the care and the challenge in regard to get to the potential clinical trials might be a problem. And sadly, and this is really one of the big concerns we have, only about 50 to 64%. This is a pretty low number in regard to those patients who get next-generation sequencing part of that disease, which we know is driven a lot by the next-generation sequencing testing. And with this, of course, the gaps, I'm going to read them on purpose backward, because really the one that we need to stress out. Number one, and more importantly, is that we don't have awareness either ourselves, and that's why we're meeting together tonight, and also our patients in regard to the criticality of that next-generation sequencing testing. And then carry on from there, we understand timing until we get the results. And thirdly, of course, the ability to get enough tumor tissue when you do this. And how do you do this? It's very easy. The earlier, the better. And if anything, patients even walking down the street to your clinic, they should be already being thought of in regard to genetic testing. And make sure you communicate with your team. As we said, teamwork is key to make sure you get the testing as deemed necessary. And with this, definitely, the education for the patient is very important. And we welcome and encourage every way we can to learn from each other how we can engage patients in regard to that discussion, recognize the importance of the appropriate therapies, applicable therapies, the testing needed, and of course, adverse events. And of course, at the same time, make sure that we really use it all in plain language. We have some kind of, all of four of us, we have some kind of examples, but of course you probably even have better examples than us. But if you feel like you have a nice example, like how you say it to your patients, please share it. We'd love to see, and we can learn from each other how we can really relate to the best possible, in the simplest language possible, the very valuable information that we owe it to our patients to understand what's going on. And with this, of course, very important to maintain the patient adherence and commitment to this. And this is really an important effort to remember. We react, we kind of start acting, and then we feel better, we start kind of faltering apart. And it's very important to maintain that importance for maintaining what we all focus on, ultimately, survival. And lastly, I would like to again acknowledge, we're very, very big thanks for the Colorectal Cancer Foundation. And full disclosure, all of us are members or involved in one way with the Cholangiocarcinoma Foundation. They do an amazing work, more importantly for the patients, but it's a beautiful way they really connected patients and experts in the field together. And proudly, they really run an annual meeting as well that humbly I helped start the first one off. And we love that it really comes from the source of where it started in Salt Lake City in Utah. And they have plenty of resources. Take the QR code if you'd like, and you can really look at their websites for always available for yourself, for your team, and your medical care team, as well as to your patients as well. So big thank you for the Cholangiocarcinoma for all the efforts they can do. With this, I'm going to pass it on to Dr. Vogel. Dr. Vogel is professor of medicine at the University of Toronto, and he's the Longo Family Chair Liver Cancer Research in Toronto, Canada. And he's going to tell us about the collaborative discussion effectively integrating immunotherapy platforms in advanced disease. Dr. Vogel, the floor is yours.
Yeah, thank you very much for the really great introduction and also into the field of cholangiocarcinoma. And I think really a lot has changed in recent years. When I started, Juan's trial in ABC02 was not yet published. We only had gemcitabine. There were hardly any trials. And we had really almost no options. And I mean, what we are discussing today here, I think is really amazing. And also to see that we have so many trials, and I mean, there's more to come. So that is something I think we can really appreciate. And still the prognosis is not where we would like to have it, but I think we have made a lot of progress, and we have definitely more options today. And we can also discuss how we would best treat our patients. And I just want to give kind of a brief introduction into a case. A male patient, 60 years old. He did not really had a significant prior history in any other chronic diseases. He recognized abdominal pain and unintentional weight loss, presented it in the hospitals, and with all the workup that was done, an intrahepatic cholangiocarcinoma was diagnosed. Because of his pain, he was a little bit impaired in his overall well-being. And you can see here the imaging. I mean, it's just one screenshot, but he had multiple lesions, so it was not a single lesion. It was still liver limited, but it was not a candidate for surgery. This is what I can say for now. I don't know whether we want to start the discussion right away or whether we want to go into the evidence first. But maybe any thoughts?
Yeah, I think the fact that it's liver limited, it's always great to bring these patients to tumor board in a multidisciplinary fashion, because in addition to having systemic therapy, we do have liver-directed therapies. There are certain centers that are doing liver transplant now. And so there's certain treatment that we could do up front, but really thinking about the holistic journey of the patient with the different specialties involved, it's helpful to get everyone's opinion.
And please, just raise of hand. Would like to see who has access to tumor board. Just raise of hands.
Not too many hands.
Not too many, yeah. But thanks for, and again, frankly, we're trying to acknowledge that's a challenge that we have. But thanks for those who shared with us. Good.
Yeah, but I think that's a really important point, and we are learning that liver limited is different, right? I still prefer starting with systemic if surgery is not an option, but I think in the course of the disease, we definitely need to rediscuss these patients and see whether we can add any local therapies, which can be radiation, internal, external, whatsoever. Okay, but so he was a candidate for systemic treatment first, at least. And I mean, patients are, you mentioned the Cholangiocarcinoma Foundation. We have C3 in Canada, so we have more patient-oriented societies and foundations that really help us. And we do see more, I think, educated patients. And immunotherapy is one of the words you hear from most patients coming to the clinic. Can I get immunotherapy, and what would I get? And we do have options. I mean, I think the field is rapidly evolving at the moment. I mean, we started with the PD-1, PD-L1 antibodies, added CTLA-4, which really was the dominant topic in recent years. But now we are getting more bispecific, trispecific antibodies where we can really direct the immune system and activate the immune system in the tumor compartment, which is really exciting. CAR T cells is definitely something we are all expecting, and now we are seeing the first trial with CAR T cells. So there's definitely more to come. At the moment, the focus is certainly on the antibodies, PD-1, PD-L1, and CTLA-4, and we do have evidence, and this is also recommended in the guidelines. When you don't know what you should do, you go to your guidelines. You can see we have here two IO-based combinations that are recommended, durvalumab and pembrolizumab, based on two large phase 3 studies, and we will review the evidence in a minute. Of course, we also have some subgroups within the solid cancers which may respond or which respond better to the immunotherapy, MSI, TMB high, and here we have also some tumor agnostic approvals for pembro and nivo-ipi in these group of patients. And you can see we have also listed many systemic therapies, so we can really choose how we best treat our patients. And when we go to further lines, Ghassan has already mentioned that really, unfortunately, not all of our patients can really make it to second, third line. Only half of them maybe to second line. But here we also have some recommendations for immunotherapy if they have not received IO in the first line setting. So there's clearly recommendations for immunotherapy, and it should be given to all patients in either first line or second line. And why? Because we have two large phase 3 studies which provided the evidence to use immunotherapy in the setting. We will briefly review the two studies. There are slight differences in the design and maybe also in the outcome, but together they clearly support the use of immunotherapy in biliary tract cancer. So starting with the TOPAZ study, which was the first study that was reported, here the chemotherapy backbone of gemcitabine cisplatin was used, which was our standard of care since more than 20 years, or 20 years. And durvalumab was added for 8 cycles, 6 months. And then we switched to a maintenance therapy, which is also good from a patient's perspective, that there was a time point when chemotherapy can be stopped. And I think we have now also more evidence from a retrospective studies that it's really justified to not continue with a doublet chemotherapy until progression. And when we look at the primary endpoint was, of course, in this setting, overall survival. These are the survival curves. They are updated once in a while, and I think with all the updates, the initial results were confirmed. We do see a significant benefit in overall survival. That what we have seen in the control arm was more or less what we have expected based on the ABC02 study, and with the addition of durvalumab, we do add efficacy. The curves are separating after around 6 months, and then you can see we do see more patients with long-term survival, and this is probably what we are now looking more to. And when we use immunotherapy anyway, the tail of the curve, the long-term survivors, which I think is something definitely we can also discuss, and what we really need to value when we use immunotherapies in many solid tumors. In terms of subgroup analysis, I think they are important. They can help us develop new hypotheses, maybe also to adjust the treatment if we do think that patients may not benefit or it may even be harmful. In the 2 phase 3 studies in BTC, we do not really see any significant outlier, I would say. I mean, if you do a lot of subgroup analyses, they are not all aligned on one line. You have some which are maybe have where it suggested that the benefit might be a little bit more or less. But overall, I think in all the subgroups, the experimental arm is favored, and we do not have a subgroup in which we would say, based on the evidence, that we should not use the immunotherapy. In terms of response, of course, we also look at the secondary endpoints. When we think about what we have said before, that we would try specifically patients with liver-limited disease to local therapies, then downsizing is also something we may want to consider. And you can see here with the addition of durvalumab, we can achieve a higher response rate. And again, duration of response is longer, and you can again acknowledge the tail of the curve, which is in line with these delayed effects we see with the immunotherapy, and we do see this long-term benefit for the patients. When we discuss efficacy, we of course need to talk about toxicity. And I would think if I would not highlight here which arm is the control arm and which arm is the experimental arm, it would be very hard for you to decide which one is which. because the numbers are almost identical. You can see there are a lot of numbers, but when you go there one by one, you can see that they are very close together, suggesting that much of the toxicity we do see with this regimen is driven by the chemotherapy, and that with the addition of the checkpoint inhibitor, we do not add much toxicity. Of course, we add toxicities because we are introducing the immunotherapy. And now I cannot move forward, so maybe you can, here. So, and this basically has also been confirmed in the second study. So the second study that was published shortly after the TOPAZ study, the Keynote 966 study, here not durvalumab was used, but pembrolizumab. It was also a very large study, as you can see, more than 1,000 patients that were included. Here, patients were able to continue with the gemcitabine beyond the 8 cycles and the 6 month. And I think that's also something we can discuss, whether it's meaningful or not to continue with gemcitabine after 6 months. Before we had the introduction of the immunity therapy, I was always a little bit hesitant to completely stop treatment. And for me, it feels better to continue with something, at least the immunotherapy. Whether we really need to add gemcitabine is something we can maybe discuss later. So this is a slight difference to the TOPAZ study where chemo was completely stopped. In terms of efficacy, the hazard ratio is very similar to what we have observed in TOPAZ. Here curves are separating a little bit earlier, but they are also coming a little bit more together at the tail of the curve, so this is not so pronounced as we have seen it in the TOPAZ studies, but in the end it confirms that we do see a significant improvement in overall survival with the addition of the immunotherapy. Again, when we look at the hazard ratio, you can see the confidence intervals are widely overlapping. Some are around 1, but again, almost all subgroups favor the experimental arm, and again, based on what we are seeing here and with what we have seen in TOPAZ, I think we do not have a strong argument to exclude any patients with biliary tract cancer from the immunotherapy, and this is what I would not do in my clinical practice. In terms of side effects, it's very similar picture to what I've mentioned before. Again, the numbers are very, very similar. Of course, we do see more immune-related side effects, but also here, just to highlight maybe discontinuation of all study medication, there's no difference between the experimental and the control arm. Is this enough? Do we need more data? And we just want to highlight one study, the Tourmaline study, in which we basically would like to generate some more data, whether we can use also other chemotherapy backbones. Yeah? And I think we have some global differences. We have seen some interesting data for triplet chemotherapy, even so the phase 3 study was negative. Some patients may not to be considered as fit enough for doublet chemotherapy. Some may have contraindications against cisplatinum. So for some patients, we may not use our standard of care, but some of the other chemotherapies that I mentioned here, and this is basically evaluated in the Tourmaline 3B study, at least to get some also safety data that we can add durvalumab also to other chemotherapies backbones, which I would definitely expect, but it's good to have some prospective evidence for that. Coming now back to our patient, again, we need to make a decision here, and we need to decide how we should treat these patients. And here we ask for your help, and the question should show up now. Okay, so here you can scan the code, and the question is, how would you treat these patients? Male patient, good performance status. At the moment, no known fusions, and we will discuss genetic alterations, and we will discuss them in a minute. So treat with nivo monotherapy, interesting, pembrolizumab monotherapy. Would you choose any chemoimmunotherapy? Would you consider just chemotherapy combinations, or would you say, okay, no, I don't want to go with systemic, I go for radiation, and then I will try surgery. So interesting options, and please vote now. Okay, I think it looks like we have already a clear winner, and I would fully agree. So he would. I think we can go back to the talk, and I think we also started Gemcis Durva. Of course, I think this is also something we may want to highlight. There are at the moment a lot of studies. Ghassan has highlighted not only to a minority of our patients clinical trials or have access to clinical trials, but there are clinical trials. I think we can move on. Again, can you go back to the slides? So there are, can you go back to the slides? Okay, so there are a couple of studies which are ongoing, combinations with chemotherapy, local therapies specifically for the liver limited, also with some studies like local treatments like Y90. So I think there are a lot of interesting ongoing studies in which patients could be recruited. Again, we have highlighted the treatment, and I have also highlighted that we do not add much toxicity, but of course we need to explain that we can expect immune-related side effects when we use the checkpoint inhibitors. In the majority of our cases, as in my cases, as highlighted here also, we do see a lot of skin toxicity. Thyroid is something we need to look at, GI toxicities. But most of these side effects, specifically the severe side effects, are in single digits, so that they are definitely manageable. But of course, we need to explain them depending on whether we use monotherapies or combination therapies. We see them more frequently. When we add CTLA-4, we usually also have more steroid use for these patients. And when you look at the timing of when do these side effects occur, usually they occur very early on treatment, but in the end they can occur at any time. So we always need to be aware and need to monitor our patients whether they develop any immune-related side effects. And then, of course, we need to treat them. If they are really mild and specifically for the skin toxicities, we would tend to continue and just use some local treatments. If they are more severe, second, third grade, we of course need to find the right time point to initiate immunosuppressive therapies, which would be for lower grade side effects, corticosteroids, 0.5 to 1 mg per kg per day. And we would increase that dose if we have higher grade toxicities. And also for the diarrhea, we would also probably start with a higher dose of steroids to treat them. So this is my last slide, and maybe a brief discussion on how you treat immune-related side effects in this patient population, and if you have any concerns with that. This patient developed grade 2 colitis. So maybe some thoughts from you. How would you treat him, and do you think that the immune-related side effects are a big problem for these patients?
Yeah, thanks so much. Actually, a question already, we have it here, and thanks so much, Dr. Vogel. So again, we got more than one of our colleagues asking us, how are we going to choose between Gemcis durvalumab and Gemcis pembrolizumab?
I think we can't. I think we have two studies which are positive, which is good. So they are both in the same direction and support the use of checkpoint inhibitors. I think based on the profile, we cannot say that one drug is more effective than the other. Also, when we look at the subgroups, the only difference may be the question whether we should continue the design of the study, whether we should continue with the gemcitabine. Personally, I don't believe in that, and I would stop Gemcis completely, and I would not continue with gemcitabine. But maybe something we can discuss. I mean, would you, or does anybody of you continue with the gemcitabine?
Yeah, it's a great question. As noted, you can't really compare. The outcomes of the studies are very similar. So it would suggest that you could do either. You do a comment that you had made before. I find it very difficult actually to stop the cytotoxics when someone is still responding and tolerating it well. And usually I'll do a shared decision-making model with patients at that time. For patients that are doing great with responding disease, they'll often continue. For those patients that may be older, maybe suffering from toxicity related to the cytotoxic, I'd consider stopping it. But I think either approach is acceptable
And I think it's a good point. We really need to discuss this with the patient, right?
Yeah.
Because it's really interesting how different some patients respond to this question, right? I mean, some are really happy. 6 months, I'm done, I can stop, right? And others don't really want to stop, right? Because they think, I mean, we're losing effective treatment. And I think this is definitely also something we consider for our decision making.
And just to kind of take another perspective, Dr. Goyal, Lipka, one of our colleagues is asking, and I think already Dr. Vogel spoke about it, but the patient with ulcerative colitis, and no question that this has been a little bit a challenge in regard to the treatment with the checkpoint inhibitors. Tell us in reality, what do you do in your practice?
Yeah, I would say when checkpoint inhibitors first came out, I think we were a lot shyer about treating patients with autoimmune diseases with checkpoint inhibitors. But I think now we've all had at least a decade of experience with these drugs, and I think we're much bolder, recognizing that cancer is fatal, and being able to treat ulcerative colitis with the new drugs that we have is very manageable. And so, especially people who have had stable ulcerative colitis without major flares in the last 6 to 12 months, I'm much more open to giving the checkpoint inhibitor, always in concert with their gastroenterologist, and having a conversation about if this person did have a flare, what are the options, always shared decision-making with the patient. But there's some data out of MD Anderson that patients who have primary sclerosing cholangitis actually do just fine oftentimes with checkpoint inhibitors and don't tend to have repeated flares with checkpoint inhibitors. So I would say there's a lot more data out there that it's reasonably safe, depending on the disease course of the autoimmune disease, to go ahead and treat in collaboration with the specialists.
Fair, thanks. Yeah, so with this, we're going to carry on. And while you're on, it's really a great warm welcome to again introduce our dear colleague, Dr. Lipka Goyal, who's the Director of Gastrointestinal Oncology and Associate Professor of Medicine at Division of Oncology at Stanford University in Palo Alto, California. And Dr. Goyal is going to tell us about the evolving use of targeted therapy in biliary tract cancer, specifically, and the FGFR2. Dr. Goyal, the floor is yours.
Thank you. Thank you for those two great talks to introduce the field, and thank you to all of you for spending your night at GI ASCO with us. I feel particularly honored to be among this cast of characters because everyone on this podium has made history in the talk that I'm about to give, and even members of our audience have made history in cholangiocarcinoma in the talk that I'm about to give, so I will call that out as I go along. So my talk has 4 parts. It's going to be diagnosis, treatment, diagnosis, treatment. So diagnosis, what is the molecular profiling that we do to be able to identify targets? Treatment, I'm going to focus on FGFR inhibitors. This is the first class of drugs that was approved in cholangiocarcinoma. Third, I'll talk about when those drugs fail, why do they fail, so how do we diagnose and identify the mechanisms of resistance? And finally, treatment, when we identify resistance, what are potential solutions for that? So this is where the timeline has been for cholangiocarcinoma. Chemotherapy has been the stalwart in this disease for a decade. From 2009 to 2020, what we had was chemotherapy. And we have Juan Valle in the audience from the Cholangiocarcinoma Foundation, who, as Arndt mentioned, led the ABC02 trial. And that team put cholangiocarcinoma into the consciousness of the oncology community. It was a New England Journal of Medicine paper. Cholangiocarcinoma would never written in the New England Journal of Medicine, as far as I know. And this is when more drug development started for cholangiocarcinoma. But then the last 5 years, since 2020, there have been multiple drug approvals in cholangiocarcinoma, as Arndt mentioned, both durvalumab and pembrolizumab, and then multiple targeted therapies. So Arndt and Ghassan made history with the first ever approval in cholangiocarcinoma, getting pemigatinib approved with Incyte. And then also futibatinib was approved with the support of the development by Taiho. And then evosidenib is a IDH1 inhibitor by Servier. So I'm going to talk about FGFR inhibitors, and then going to pass it back to Ghassan to talk about evosidenib. And then these are all the tissue agnostic approvals that all have relevance in cholangiocarcinoma. And at the end, we're going to pass it over to Jim to talk about HER2 inhibitors. And Dr. Harding made history because he led the development with zanidatamab with Jazz Pharmaceuticals. So many different approvals that are relevant for cholangiocarcinoma, And this is to Ghassan's comment that when a patient's walking down the street coming to clinic, we want everyone to be asking their doctor, can I please get profiling as soon as they walk in the door? So these are the panoply of different alterations that we're seeing in cholangiocarcinoma. Some people call intrahepatic cholangiocarcinoma the lung cancer among GI cancers because 40 to 50% of patients with intrahepatic cholangiocarcinoma have some sort of actionable target. And everything on the right, you can see there's a variety of different NCCN guideline recommended targeted agents. So here's a case. We have Sherry, who's a 65-year-old woman who has unresectable cholangio. She got Durva, Gem, and Cis up front and then had progression 4 months later. So Dr. Harding, what would you do next for this patient once you know that they're developing progression?
I'd want to see the results of the molecular profile. But I mean, yeah, so I think that's obviously critical.
Yeah, molecular profiling for everyone. So, you know, we used to think about biliary tract cancers as anatomic subgroups. We still do, but we now recognize within these anatomic subgroups there's a lot of heterogeneity. So you can see on the right side the different alterations that you see in the 3 different anatomic subsites of biliary tract cancers: gallbladder cancer, intrahepatic cholangio, and extrahepatic cholangio. So we test for all of these. There's a variety of different platforms that we can use that have a variety of pros and cons: next generation sequencing, amplicon-based approaches, anchored multiplex PCR, FISH, and IHC. You need a different amount of RNA or DNA for these different tests, and some of them are able to catch FGFR2 fusions when the partner is known and some when the partner is unknown. So there's different reasons to use different platforms. I would say majority of patients are these days profiled on next generation sequencing platforms. We know that up to 20 to 25% of the time when we do biopsies, the biopsies fail to actually give us enough material to do molecular profiling. So a big technological advancement has been liquid biopsies. The key thing to understand whenever you're ordering a test as an oncologist is what are the limits of that test. So with liquid biopsy tests, they tend to pick up the mutations very well. So for IDH1 mutations, in this study of 1,700 patients that got Guardant 360, 87% of the IDH1 mutations picked up in tissue were picked up in blood. When it came to FGFR2 fusions, only 18% were detected. And so the platform has now improved since this paper was published, but overall, it really depends on your platform as to whether or not you're going to pick this up. The concordance in the futibatinib phase 2 study was 87% with a different liquid biopsy platform, so the technology is certainly improving. The key is, if you do not see an FGFR2 fusion on a liquid biopsy, it would not assume that that patient does not have a fusion. So case continued. Dr. Harding, you got your wish, and the NGS results came back. The patient has an FGFR2 BIC1 fusion. Can I come to you again? How would you proceed?
Yeah, so I think clearly I would recommend an FGFR inhibitor at this point. I mean, I think it would be reasonable to discuss cytotoxics as well, given that there's data in the second-line space. Although non-comparative, I would still favor an FGFR inhibitor.
Great, so let's look at the efficacy for the FGFR inhibitors. So there are 2 FGFR inhibitors that have been approved. One is pemigatinib, that was the first one. This is a reversible FGFR inhibitor. It hits FGFR 1 through 3. This was a study of patients who have FGFR2 fusion or rearrangement positive cholangiocarcinoma. They all had prior chemotherapy, and the response rate was about 36%. In unselected population of patients with biliary tract cancers, when you use chemotherapy, FOLFOX specifically, the response rate is 5%. So we were all very excited to see these responses when giving pemigatinib. And you can see the progression-free survival of 6.9 months and the duration of response 9.1 months. Futibatinib is a similar drug, but one key difference is that it's an irreversible inhibitor. It binds covalently to the receptor. It hits FGFR 1 through 4. The response rate was about 42%, and you can see the duration of response was 9.7 months. So both comparable data. Ghassan, can I ask you, people often say to me, Dr. Goyal, how do you choose when someone has an FGFR2 fusion? Should I give Pemi or Futi?
Yeah. No, again, one of the challenges in regard to those two therapies that really has been no comparator work between the two, and probably a little bit of default in regard to what you really are experienced with or kind of, get, access to. But intriguingly, and Dr. Goyal, myself, and other colleagues were trying to really actually line this up, and with the view that ultimately the genetic alterations of the FGFR2 fusions are not necessarily a random event. It's actually a deterministic event, i.e. you only have one choice of many few, and the question is, can we sequence those kind of components? And no doubt there's pluses and minuses over here, because no doubt that the expansion to the FGF1, 2, 3, 4 for the futibatinib might be inviting, but to be fair, most of them, as we heard from the Goyal, are really in the FGFR2. So as you know, I'm kind of going through a long rally over here, but admittedly, there's no really specific choice per se. It's really by default. And interestingly, however, if you really, and I return back to you, Lipika, if a patient fail on one, would you go to the other?
Yeah, that's a really great question. It's a question in the field. I agree with you, Ghassan, that I think both of these are very reasonable upfront choices. If someone got pemigatinib first, we certainly apply to insurance and see if we can think about doing futibatinib, but I'll also talk about a series of different clinical trials of next-generation inhibitors that might actually overcome some of the resistance to pemigatinib. And I would say that the one biomarker that I sometimes use to choose between pemi and futi up front is whether or not they have a TP53 co-mutation. Because there's some data that in the Fight 202 study for pemigatinib, there were 0 responses in patients with a TP53 mutation. And in Phoenix, there were people who had a TP53 mutation and had responses. And then this was also confirmed in the Fight 207 study, which was a broader study of pemigatinib in many different tumor types. And also in that study, no one with a TP53 mutation had a response. These are subgroup analyses, very small numbers of patients, but generally, that's the one scenario that I might favor futibatinib. These drugs were approved by the FDA and the EMA, and futi has also been approved in Japan. Just to say that in follow-up data, with further follow-up, pemigatinib continued to show a high response rate with 37%. Median DOR was the same at 9.1. And then for real-world data, again, the response rate with pemigatinib here was around 60%, and the PFS was around 7.4 months. So overall, just continued to show that in the real world, this drug is showing clinical benefit. And so one of the things that comes up when you get accelerated approval in single-arm studies is what's going to be the confirmatory study. We'll talk at the very end of the talk about confirmatory studies for FGFR, but this is one study that's ongoing right now with the FDA's goal of trying to give patients just enough drug to have efficacy, but not more, because we want to avoid toxicities. This is a study to find the right dose of futibatinib. 20 is the approved dose, but it's a study of 20 milligrams versus 16 milligrams in the target population where it got approved, patients with FGFR2 fusion-positive cholangio. So a question for all of you. So you're managing a patient with a 58-year-old patient with metastatic biliary tract cancer. The molecular profiling shows the patient has an FGFR2 alteration, specifically a fusion. What treatment would you select? So yeah, overall, right now, FGFR inhibitor monotherapy is what is FDA approved. It's an interesting point about combining pemigatinib with chemotherapy. Certainly something that is not being tested, potentially because of the toxicities of these overlapping, but certainly FGFR inhibitor monotherapy would be one way to go. Next is key toxicities. So I will open this up because I think it's more fun to talk about this as oncologists than for me to just talk by myself. Dr. Vogel, you've given a lot of FGFR inhibitors. Can you share what toxicities patients have? And sorry, not more fun, I meant more informative.
Yeah, so I think among the most frequent toxicity is certainly the hyperphosphatemia, which is basically related to the mechanism of action. The question is it really a toxicity or is it a sign of efficacy? because we do have target inhibition. I think it's always difficult to decide. I mean, we don't really know what is the dose we need, right? You mentioned the study with futibatinib, whether maybe also lower dose with less toxicity, hopefully, but similar efficacy. But we don't know yet, right? And we may come to a point to say that more drug, more tox, more efficacy, right? That it somehow goes hand in hand. So with the hyperphosphatemia, it's definitely something we need to monitor. At some point, we should treat it, but I would be cautious to lower the dose as a first step. I think we should not do that. And then, I mean, among the more annoying toxicities for the patients, definitely the GI toxicity, stomatitis, nail toxicity, and this is definitely something we need to discuss with the patient. They need to be prepared of this, for this, and this can lead to dose reductions for sure.
Yeah, I totally agree. I feel the mouth sores, the nail toxicity, and the hand-foot syndrome are the three things patients complain about the most on these drugs. But the key is to monitor the phosphorus and for everyone to get a baseline eye exam, because people can get retinal detachment with this drug, this class of drugs. So because, as Art mentioned, hyperphosphatemia is really common, there are guidelines now about how to manage hyperphosphatemia. Dr. Harding, is there a certain target phosphorus that you try to keep patients under and continue without having to stop drug?
Yeah, so I mean, I think it's important to monitor it, and here, institution of phosphate binders, I'd say probably in clinical practice for a range of 5 to even 6. If someone is asymptomatic, I would just monitor it, because you can overcorrect for that and end up with hypophosphatemia, which can be symptomatic and then hard to manage afterward.
That's a great point. Pemigatinib is 3 weeks on, 1 week off, and it's really important to educate patients that in that 1 week off, they need to stop their phosphorus binders. And when we first started giving these drugs, we would often hold the drugs with 5.5 as a phosphorus. We would go down on the doses, but as Jim is saying, we really try to push dose, and I often do not hold drug, even if it's between 6 and 7. I'll just start those 5 phos binders and keep going. Okay, so if someone has high phosphorus, 6.5, I think we talked about how we would go ahead and give the phos binders and encourage people to hydrate well and avoid constipation. Now, after the FGFR inhibitor, we see that the patient has an FGFR2 V565I mutation, one of the gatekeeper mutations. Dr. Vogel, can you share what you think about that mutation on liquid biopsy?
Yeah, I think that's really important, and goes a little bit in the direction we discussed before, that we can sequentially treat our patients, right? And that we have now newer drugs, and we know that some of these drugs can overcome these resistance mutations. And it's very interesting. And I mean, you named us who did which studies, and we have to highlight your studies on this topic, right, which are really excellent and also published in recent months in Annals of Oncology on the occurrence and frequency of these on-target resistance mutations. And that's definitely something very interesting. I think it's not research anymore. It's something that really has clinical implication, and I strongly recommend that we do at least liquid biopsy, and some patients are not shedding, so then we do a rebiopsy to really understand what genetic alterations cause the resistance, and specifically for those patients that responded well to the treatment, we would expect with PEMI and FUTI some of these on-target resistance mutations.
I think that's a great point. It started off as research to do liquid biopsies after FGFR inhibitors, but now I think it's standard of care. It's really how we were able to work with companies to develop the next generation of inhibitors by letting people know what are the mechanisms of resistance. And so I just want to also give a shout out to the Cholangiocarcinoma Foundation. One of the things that Ghassan said at the very beginning is what amazing work they do for patients. For me, and I think for everyone on this stage, one of the most amazing things they've done is connect the oncologists and connect the pharmaceutical companies and biotech companies together into a community. This is a study that we did where we brought together 10 institutions, 3 pharmaceutical companies, and a lab to understand FGFR resistance. And each individual institution only had 2 or 3 patients worth of data, but together we were able to put 77 patients together. And it was very much because of the connections that many of us have made at the conference, the annual conference, and just all the program that they do to bring the community together. So this study showed that the 2 key alterations that we see are in the gatekeeper and in the molecular brake mutation, both on reversible inhibitors and irreversible inhibitors. But luckily, there's a whole series of next-generation inhibitors that we can consider. Lirafugratinib, tidangatinib, a drug by Cogent, and a drug by Tyra. So briefly, I'll just go through these. Lirafugratinib is a drug that's an FGFR2 specific inhibitor, so we want to avoid the hyperphosphatemia, avoid some of the diarrhea that you get from hitting the other FGFR inhibitors. You can see with the green that it theoretically is supposed to overcome nearly all the resistance mutations, and certainly in patients who have FGFR2 fusions and rearrangements, it's definitely showing activity both in people who have never had an FGFR inhibitor and also people who had a prior FGFR inhibitor. Tidangatinib is a little different because it's a multi-kinase inhibitor. The special thing about tidangatinib, it doesn't bind in the inside pocket like the other FGFR inhibitors, so it's potentially less susceptible to the gatekeeper mutation. It binds more a little bit further outside. And you can see from the red light, green light plot here too, all the green with tidangatinib. It also theoretically is supposed to overcome many of the resistance mutations. And this has 3 hydrogen bonds to FGFR2 as opposed to 2 hydrogen bonds, so it binds quite tightly to the receptor. And you can see here in people previously treated with an FGFR inhibitor, we're seeing multiple people having responses. This has led to a phase 3 trial that's going on right now. It's the only phase 3 trial going on right now in patients who have had a prior FGFR inhibitor. It's a global study, and we're hopeful to be able to have a new FGFR inhibitor to be approved after pemigatinib or futibatinib. The 2 other drugs are Tyra-200. This nicely shows with all the FGFR inhibitors on the left side, when you look at enzymatic IC50s, you can see that for different mutations, different drugs have different performance. What does that mean? That means potentially one day, based on the liquid biopsy identifying what resistance mutation someone has, we might choose their next FGFR inhibitor based on that. Or there might be one drug that wins it all and can overcome them all. So you can see with Tyra, it has potency against many of the different FGFR mutations. Right now, there's an ongoing phase 1 study in dose escalation. And lastly, the Cogent study is a study that is another FGFR 1 through 3 inhibitor. This is in dose escalation right now. It is mainly focused on FGFR 2 and 3. It spares FGFR 1 likely. Sorry, it's an FGFR 2-3 inhibitor, not FGFR 1 through 3. And this hopefully will also have activity post FGFR inhibitor. So this is my last slide. Wanted to just bring up, when we have these targeted therapies and they get accelerated approval, and this is not just in cholangiocarcinoma, but really across oncology, this is a big conversation. How do we do a confirmatory study? So Ghassan led this phase 3 study of infigratinib versus chemotherapy. The big question is, FGFR inhibitors have so much efficacy in the second and third line, and plus, can they beat chemotherapy in the first line? Ghassan, what were some of the messages that we learned from this?
Yeah, thanks so much, Lipika. So this was collaborative work that many of us have been involved in. And if anything, as you can see, this was published right here at GISCO last year. We actually screened close to 1,100 patients, and we were able only to accrue about like 70 patients. Why is that? Because of the rarity of the genetic alteration. And the question is, as Dr. Goyal asked, like, are we really using the appropriate technique in regard to proving and prove that these therapies work or not? Do you really need a phase 3 clinical trial? We're not sure. And that's really where we're kind of like bringing this question so we can work hopefully with the agency to try to find other approaches or mechanistic approaches to really get those therapy to the patient in a rare illness to begin with a rare alteration, to kind of, not await for a clinical trial. As we can see, realistically, will take forever. It will probably never happen, as we just showed with the Proof 0301. And actually, to that, believe it or not, sadly, the sponsor of the infigratinib decided to actually just, get rid of the asset, and there's no more infigratinib that really could have been beneficial for the patients. But thankfully, we still have the futibatinib and the pemigatinib that can help the patients as well. But these are big questions and big challenges that we're all going to face at this point in time.
Thank you very much.
Sure. Great. Well, great applause for Dr. Goyal. And I will spend myself a few minutes to talk about the IDH mutation, biliary tract cancer. And if anything, you know that there are certain alterations that can happen. As we can see, some of them we really know about in regard to certain, appropriate therapeutic proven therapies like the NTRK, the MSI high, high tumor mutational burden, and of course the BRAF V600D. But on the other hand, there are some of them that really did come a little bit more by serendipitous chance. And among those, we're going to touch on two more. We already touched on the FGFR2, and now we're going to talk about the IDH1, and then Dr. Harding will carry on with her to follow. And the ivosidenib study was a randomized clinical trial that tried to look into patients with mutated IDH1 being randomized to a ivosidenib, which is the therapy that targets the mutated IDH1, versus placebo. And the aim of the study, of course, to look for a better outcome. This is one more a shout out for the Cholangiocarcinoma Foundation, especially for their advocacy group over here, because if anything, that study was supposed to just look onto the therapy versus placebo, but understandably, the advocacy, patient advocates, patients themselves, one said, like, if I have that mutation, it seems that there is a potential for the benefit based on early study results. Why don't I get at least an opportunity to test it rather than just get placebo? So for that, we listened and we worked together and we made the study to have a crossover, i.e. patient will get either the ivosidenib or the placebo, and if they were to progress on the placebo, they were allowed to cross over to the ivosidenib as well. And Dory, we still were able to get data from that. As you can see, the survival did not really matter much between the ivosidenib and the placebo. 10 months versus 7.5. Understand, because there's a crossover, so you really kind of diluted your placebo versus ivosidenib therapy overall survival because of that crossover. Interestingly, the PFS did not really matter much, maybe a little bit with an advantage for the ivosidenib. But to follow to that, we had another analysis, and we thank our colleagues in the biostatistics who really helped us using the rank-preserved substructural failure mutation, failure time method, which really is more PRSFT for short, will help us to really pretend as if the patient on the placebo never crossed over. And as you can see over here in the dark blue, you can see the ivosidenib with still that survival, about 10 months or so. But when you look at the green, which are the patients who really were on the placebo, but as if they really never crossed to the ivosidenib, as if they remained on placebo, we can see a major improvement where it's about like 5 months or so, and with a hazard ratio that dropped to 0.46. So clearly this therapy does work for patients. Definitely it has a survival advantage as well. With this said, yes, like any other therapy, there's potential for adverse events. Thankfully, in general, it's rather acceptably okay, but we can see clearly over here that we had some events that mainly relate to some possible abdominal symptoms, including pain, ascites, as well as alteration of the liver function test, add to some nausea and diarrhea. In general, though, we have noticed that they are really minimal and would not necessarily be limiting to the patients, as we can see. For example, as only one example, the ascites was limited to only a few patients as well. By the way, the effort in regard to the ivosidenib, as you all know, started in GBM and in the brain, and we are here in San Francisco at GI-ASCO, but interestingly, this whole story of the ivosidenib for cholangiocarcinoma started at ASCO, and literally you guys remember ASCO, you have that bridge over the highway from the east halls to the main halls of the McCormick, and interestingly, right there, we went very hard explaining to the company and to that, in regard to that potential for cholangiocarcinoma. So you can say that ivosidenib was born on that bridge at ASCO for the cholangiocarcinoma. But we really great thanks to really the support that now is the hand of Servier that really got the therapy on. And the good news is we are getting more appropriate approaches. Interestingly, that's a little bit intriguing. We have some assets, you can see them here, no need to go over each one of them, except that at least I'll acknowledge that the olaparib plus durvalumab, and you wonder like, whoa, you're going a PARP inhibitor plus a anti-PD-L1, but intriguingly, it appears to be that the PARP inhibitors can have an intrigue in regard to the IDH1 mutation, add to, of course, an enhancement by the checkpoint inhibitor. So we're just waiting to see the outcome of all those studies as well. And with this, we can see that we have a patient here, our 65-year-old lady with a upfront therapy which was area-secondary cholangiocarcinoma, treated with the upfront durvalumab, gemcitabine, cisplatin. However, she progressed, and if anything, we would like to manage therapy, and the patient had a NGS testing, and of course, it has the IDH1 mutation captured. And the question is, and I'll start again here, to kind of, bring a little bit of more thoughts. Dr. Harding, Jim, your thoughts?
Yeah, I mean, at this point with an IDH1 mutation, at progression, the data presented was, very compelling for ivosidenib. I think that's reasonable.
And to challenge that, why not to give, for example, chemotherapy like FOLFOX or?
I think as stated for FGFR, it's an important conversation to have with the patient because there are cytotoxics available. I generally find that ivosidenib is very well tolerated. It's cytostatic in its action for sure, but as to the PFS curves, there's a nice tail of the curve. There does appear to be some benefit in survival. It's an oral medicine, less toxic. It might be reasonable to do sooner rather than later in someone with a gastrointestinal cancer.
Fair. No, totally agreed. And please, again, we spoke about that many times, but please, we urge you, do the next-gen sequence testing as early as possible. We have patients probably in our clinic that have been on ivosidenib for years, and this really was important to give them that asset and that opportunity per se. With this, we're kind of a tad behind, but don't worry, we're catching up, and this is we're going to carry on, and we'll great delight to welcome my dear colleague from, again, Memorial Sloan Kettering Cancer Center, New York, Dr. James Harding, who actually works both with us in GI oncology, but also he's one of the kind of like dynamos of the early drug development specialty. And he's going to talk to us about his added assets, the HER2 positive biliary tract cancer. So Jim, the floor is yours.
Thank you so much. Thank you so much for the invitation, and it's great to be here with all of you. When we think about HER2, it's really a critical target for decades now in a solid tumor, and ERBB refers to the gene, HER2 refers to the protein, and HER2 is a member of the EGFR family of receptor tyrosine kinases. It doesn't have a known ligand, and the way signaling normally works is it forms a heterodimer with one of the other HER2s, HER1, 3, 4, and that ultimately leads to activation of the MAP kinase pathway as well as the PI3 kinase AKT pathway, and this is responsible for proliferation, motility, normal cellular growth. HER2 is now established to be aberrantly activated in a number of solid tumors, and the ones that we think of typically are breast and gastric cancer. And the mechanism by which it's activated is usually overexpression, secondary to gene amplification. And you can see in the little schema there, as sort of an important way of diagnosing this is usually through IHC, looking for the protein expression, which can then be reflexed and tested by in situ hybridization to see if you have an amplification. There's also single nucleotide or missense mutations in HER2 or ERB2 that drive cancer growth. And I think what we've learned across cancers is one, that these tumors that harbor alterations in HER2 tend to have a worse prognosis, and there are some data in biliary tract cancers to suggest that. Although most of those studies are retrospective in nature. Having a HER2 alteration in many tumor types is predictive of response to HER2-targeted therapy, and in fact, that can improve the prognosis, such as in breast cancer. And so what we've now observed across biliary tract cancers is HER2 is a legitimate target. We saw earlier that in intrahepatic cholangiocarcinoma, we're looking at a 3 to 5% rate of overexpression, or HER2 alteration, or ERBB2 alterations, more so in extrahepatic, where we estimate is around 10 to 15%, and the highest in gallbladder, where some reports indicate this is 30% of tumors of this nature. And so at the present time, we're lucky to have many HER2-targeted options, and you can see here from NCCN guidelines in patients that have progressed on gemcitabine-based regimens, there's a number of options: zanidatamab, trastuzumab and pertuzumab, trastuzumab deruxtecan, and the tucatinib and trastuzumab. And we'll talk about all of these in varying degree. But from a standpoint of mechanism of action, the first kind of in class for oncology were monoclonal antibodies, really trastuzumab being the first, and then pertuzumab to follow. These really targeted the extracellular domains of HER2, and the mechanism of action really is inhibition of dimerization, decrease in signaling, and usually engagement of ADCC, so killing cells by an innate immune response. Then we've seen the development of tyrosine kinase inhibitors, such as lapatinib, neratinib, and tucatinib. These work internally by blocking signaling through the receptor. And what we'll talk about mostly today are antibody-drug conjugates, which carry a cytotoxic payload while targeting HER2, and the example of this would be trastuzumab deruxtecan. And then more recently, novel bispecifics like zanidatamab that are molecularly engineered antibodies that can bind two epitopes of HER2, all of which have anti-tumor activity in biliary tract cancers. And at a sort of a very high level, this tabulates some of the efficacy data that we've seen to date, and I'm going to use it to just mention single nucleotide variants very briefly. This is not sort of a standard approach, but we know patients and tumors that harbor solely single nucleotide variants in HER2, in ERBB2, this is an oncogene, and you can have anti-tumor activity with both TKIs like neratinib as well as ADCs, and there's also been reports of that for trastuzumab and pertuzumab, but these response rates are generally low and short-lived. So the inclusion in the treatment of patients with these mutations is still unclear. When we think about HER2-targeted therapy, the mainstay now is really treating HER2 overexpressed tumors, those that are IHC3+ or IHC2+ with associated amplification. That's considered HER2 positive. HER2 0 to 1 to 2 might be a HER2 low state without amplification. It's unclear how much activity there is there. And for the remainder of the few minutes that we have, I'll focus on trastuzumab deruxtecan and zanidatamab. We'll dive into those data now. And so the ADC trastuzumab deruxtecan essentially is a monoclonal antibody to HER2, as we know, and it carries a topo-1 warhead. And the study that defined its use in an agnostic approach for HER2 IHC3+ tumors was the DESTINY pan tumor 02 study. I don't have a slide of the design, but essentially this was a basket study in endometrial, cervical, ovarian, bladder, biliary tract cancers, pancreas, and other tumors not the commonly expressing HER2 that had HER2 2 or 3+ locally or could be confirmed centrally, had progressed on at least one line of prior therapy, went on to receive trastuzumab deruxtecan at the 5.4 milligram per kilogram every 3-week schedule. This study also allowed prior HER2 exposure. And the punchline is that if you had an IHC3+ tumor There was a high response rate, about 60% across the board. The second punchline is it does seem that the histology matters. As you can see, from you go endometrial to pancreatic, the response rate diminishes. And focusing in the red box were the 40 patients with biliary tract cancers. The objective response rate in this total population was 22%. The benefit was in the IHC 3+ with a 56% objective response rate. Median duration of response there was about 8.6 months. No activity in the IHC 2+. And this is what allows the use in biliary tract cancers. The toxicity of ADCs, is the selling point of an ADC is it's not chemotherapy, but that's wrong. It is chemotherapy. ADCs still have the toxicity of chemotherapies. Namely, that's gastrointestinal toxicities, as noted there, and cytopenias, possibly just from a bystander effect of release of the warhead. The critical toxicity for T-DXd or trastuzumab deruxtecan and many ADCs is pneumonitis, and pneumonitis can be fatal. And indeed, on the Destiny pan-tumor approach, 3 or 4 patients died of pneumonitis, including one with biliary tract cancer. And so that is the toxicity that needs to be surveilled and monitored for. It's uncommon, but critical. And really, when we think about that toxicity, we really have to assess patients well up front. We frequently scan lungs for any potential inflammation and look for factors that might synergize with toxicity. Maybe prior radiation has been suggested. And if symptomatic or notable, you really do need to stop the therapy and may need to institute steroids. So that's a critical toxicity. But the drug has certain activity in biliary tract cancers and should be used and can be used. There's also now the desire to evaluate T-DXd at the frontline setting, and this is the Destiny BTC-01 study. This is taken from clinicaltrials.gov, essentially looking at patients with biliary tract cancers that are IHC 2 or 3+, based on the standard IHC with reflex-ish. And patients really on this study would receive the standard gemcis-durva or T-DXd alone or T-DXd plus rilvegostomig, which is a novel bispecific targeting PD-1 and TIGIT, with the primary objectives of one, safety of the T-DXd combo IO regimen, but also to look at overall survival from gemcis-durva to T-DXd plus rilvegostomig, specifically in the 3+ state, because that's where the majority of the activity has been observed. I'll note that in the IHC 2+, although Destiny pan-tumor-02 didn't show anti-tumor activity, a separate study noted on the table, the HERB study, did indicate that a subset of patients with 2+ IHC amplified tumors do have a response somewhere around 5%. So the question of this HER2 low state in T-DXd is still open, but an important study that we should be aware of. I'll move next to zanidatamab, which is really the first example of a HER2 bispecific approval. Here, it's a quite novel mechanism of action in that it's a bispecific that binds to 2 separate epitopes of HER2, and the molecule is structurally engineered so that you're not binding 2 epitopes on the same molecule. It will cross-link and, as noted, bind in this trans conformation. And that specific geometry has downstream effects that probably support some of the efficacy that we've observed. Namely, there is cross-linking on the surface leading to endocytosis of these complex. It impairs signaling in cells and also leads to a variety of FC-mediated cytotoxicity, and in preclinical models is superior to trastuzumab and pertuzumab. And so based on those data, So we have a question, so sorry. So which of the following best describes the mechanism of action of zanidatamab? Zanidatamab binds to PD-1 receptor, blocks its interaction with PD-L1, enhances T-cell activation. Zanidatamab simultaneously binds to two distinct HER2 epitopes, inhibiting downstream signaling. Zanidatamab binds to HER2 and delivers a cytotoxic drug, or it binds to VEGF and inhibits angiogenesis. So everybody better have gotten that one right, honestly. All right. Do I advance it? No? Oh, wait. Okay.
We'll go back to the
Go back. Play the music.
we see the result.
Gassan, I requested a different music.
No, just
Because I thought I was going to have it. I'm just kidding.
Okay, good.
Good.
Yeah. Oh, perfect.
All right. Well, that's correct.
You're happy?
Yeah, I'm happy. I was hoping for 95%, but you guys did a good job. So, all right. So very quickly, a phase 1 showed promising anti-tumor activity for zanidatamab across solid tumors. A biliary tract expansion cohort there showed about a 40% objective response rate. That prompted the Horizon BTC-01 study. It was a global phase 2 study of zanidatamab monotherapy in HER2-amplified biliary tract cancers. So in this case, patients had to progress on gemcitabine, no prior HER2 therapy allowed, and centrally had to have a HER2 amplification. And if amplified, they were placed into one of two cohorts. Cohort 1 was the HER2 positive 2 and 3 plus. Cohort 2 was IHC 0 or 1, so a HER2 low state. Primary objective was objective response in cohort 1. Zani is given every 2 weeks with scans every 8 weeks, secondary endpoints there. And here we see the waterfall plot from the initial data presentation. 67% of patients had some degree of anti-tumor, some shrinkage. The response rate in the total 80 patients was 40% or 41.3%. You can see it was in all subtypes based on color. The one notable finding is that there is a difference between IHC 3+ with a 51% response and 2+ was about a 5% response. Durable responses, the median duration of response is almost 14 months based on an updated data cut. And here are updated survival data presented by my colleague Shubham Pant at last ASCO, essentially showing the median overall survival of about 18 months for the IHC 3+ treated, and the overall study population of a median overall survival of 15.5 months. So compelling survival data in a single-arm study and worthy of continued investigation. Toxicities are quite favorable. Here is an updated safety profile, again presented recently at ASCO. No study-related deaths. The main toxicities are low-grade 1 or 2, and they may include diarrhea, infusion reactions, which are manageable, and gastrointestinal toxicities. And so there's a confirmatory study that's currently ongoing, really the BTC 302 study, which is really looking again frontline, moving this to a frontline space, biliary tract cancer patients that are HER2 positive, IHC 3 or 2+, centrally confirmed, randomizing 1-to-1 GemCis plus or minus a PD-1 antibody as a standard of care versus the same with zanidatamab. Primary endpoint here is PFS in the IHC 3+. Secondary endpoints are overall survival. This study really heavily involved patient advocacy, and we do allow up to 2 cycles of systemic therapy before initiation of zanidatamab. The benefit here, as opposed to FGFR, is that we can test by IHC, which is a rapid test and requires perhaps less tissue. So sort of a critical study to enrolling now. Quality of life here is this is the Horizon BTC-01 study was actually quite favorable and associates with response. So here we go. I guess there's the last question. So which of the following findings from Horizon BTC-01 evaluating Zani in HER2 amplified metastatic biliary tract cancer was notable? I guess here zanidatamab significantly improved PFS relative to standard of care. Zani achieved a modest objective response showing limited efficacy. PFS with Zani was significantly shorter than chemotherapy, indicating a lack of benefit. Zani demonstrated promising response and OS outcomes. All right. Cue the music. All right, they got my music this time. Good job. I'm just kidding. All right. Okay, that's right. Oh, so I'm going to be back. So I guess this is just to say that both of these drugs are now approved, or zanidatamab is accelerated approval. So that's great news.
Well, excellent. Thanks so much, Dr. Harding. Oh, you have the case. You have the case.
The case. All
Go
right.
ahead.
So here we have Sherry, again, 65-year-old, progressed on gemcitabine. Molecular testing shows HER2 amplified disease. What treatment options would you consider to manage this patient's disease? And are there any special safety signals? So maybe we can kind of ask the group, how would you approach a case like this, HER2 amplified biliary tract cancer?
Lipika.
Oh.
Yeah, so I think you have good options with both zanidatamab and trastuzumab deruxtecan as presented. As Jim mentioned, trastuzumab deruxtecan is chemotherapy. There's a chemotherapy payload, so it comes with the chemotherapy-related side effects in terms of count reductions. So depending on how people did with, for example, gemcitabine cisplatin plus IO in the front line, can they handle count reductions? If they can, trastuzumab deruxtecan is a good option. Also thinking about the pneumonitis piece, so understanding what their comorbidities are. Zanidatamab, not chemotherapy, targeted therapy, monoclonal antibody, has more GI side effects. So again, understanding sort of what their baseline is, and the side effects with both drugs are certainly manageable with good monitoring.
Yeah, I mean, Arnd, what do you think about toxicities of HER2 targeted therapy? How do you follow and manage that?
Yeah, I mean, what Lipika has said is, I think there's not really much to add. I think it's manageable. I mean, we have different drugs, different mechanism of actions, and with that, different potential side effects that need to be monitored. I mean, one thing we also need to address is access to drugs, right? I mean,
right.
So which is also something here in the US, we have very good access to drugs, which is not what we have in all other countries. So I think it's good to have so many options. I mean, sometimes you wonder, do we really need to have 2, 3, 4 drugs, right? But they all have their nuances. We can make decisions. And I mean, with all these cumulative evidence, we get these drugs also in countries which are a little bit slow in the approval and reimbursement process. And being now in Canada, I know what I'm talking about. So I think it's really good that we have drugs, we have trials where we can include patients, but we really also need to fight for that patients can have access to these drugs.
Yeah.
And we should not take this for granted.
No, that's very helpful. We're getting a lot of questions over here. So if anything, you have one more questions, I think, or this is, let's see. Yeah, this is like more like, the kind of wrap up, but, we can answer that, and then we can come to the some of the queries that many of you already shared with us. And, let's do the questions first, kind of, to be fair, because to fill you in on all what's going on. So number one is, and Jim, you worked on that before, and the question is, as you remember, Lipika just talked about the FGFR2 alterations, how they change. And you had a publication, actually, they are not referring to publication, but at least they asked the question, which is nice. IDH1, could it really alter to...
Yeah. Sure.
Your thoughts on
Yeah.
that? And what does it
So,
mean?
I mean, I think for IDH1, there has been reports that at progression, you might see the emergence of an IDH2 alteration, so-called deemed an isoform switch. There are also second site mutations in IDH1 that have been identified at progression in IDH1 mutant tumors. I think there was a lot of interest in that initially. However, I would say as we've sequenced more and more patients, both with liquid biopsy as well as like tumor biopsy, that seems to be a quite infrequent mechanism of action. And one of the studies that you had on the slide, the Loxo-Lilly compound, was actually designed to overcome that resistance. And as you know, in the public and in presentations, you really don't see so much of a major increase in efficacy, suggesting that even though those are legitimate and confirmed across multiple studies as a potential mechanism of resistance, is probably infrequent, and we have to think about IDH in a different way.
Yeah.
That's my thought.
No, very, very thoughtful. Dr. Goyal, let me pick up for you a question relates more to the different anti-VEGFR2, as we said, pemigatinib and futibatinib. Mechanism of action, can it explain at all the difference in regard to the median PFS
Sorry, what, the
between the
mechanism of action
pemigatinib and the
change?
futibatinib, exactly?
I mean, theoretically, that's what they say about covalent inhibitors. And when you look at lung cancer drugs for EGFR and ALK, the covalent inhibitors tend to have a slightly longer PFS. It's like the foot on the gas for longer, so potentially can overall overcome some of the resistance mechanisms. In the end, is that the reason? Does it have to do with safety and tolerability? Does it have to do with something else? Unknown exactly why that PFS is longer, but certainly could be due to the mechanism of action of futibatinib.
Fair, fair. Thank you for that. And go back to checkpoint inhibitors and Vogel aren't. That's interesting. You know, together, as you know, we worked on this in HCC, but somebody's asking any data at all or any understanding got to immune-mediated adverse events and outcome based on either the durvalumab or pembrolizumab?
Yeah.
That's a good question.
I think we have like a tendency in many tumor types that we do see with more immune-related side effects, so more toxicity, more efficacy. I think in cholangiocarcinoma, it's still early to tell, but there's, I think, if I remember correctly, for TOPAZ, we have seen similar data that that patients that develop side effects may respond better and have better outcomes. Yeah. So this is, I mean, sometimes for the patients helpful if they develop these side effects that in the end outcome tends to be better.
Yeah, fair. Yeah, this is the more to kind of probe on, but at least, yes, the suggestion is there for sure. We'll circle back to Dr. Harding. That's a good one too. Any potential for having more than, we spoke about, IDH1, we spoke about FGFR2, we spoke about HER2. Can you have more than one together? And if so, how do you line up therapies? That's a nice one.
So can you sequence the treatment of HER2?
In other words, you have more than one genetic alteration.
Yeah.
Can it happen first? And number two, if it does happen, who do you treat first?
Right,
Or how do you treat them together?
So, HER2 in general has been mutually exclusive with many of these drivers. There may be some very slight overlap, but I don't think that is a significant concern there. They're genomically discrete.
Yeah, and to the credit of our friend also, Dr. Maeve Lowry, who was at Sloan Kettering and now in Dublin, she published on that one of the first or the early next-generation sequencing testing, and actually we came with a name for it. We call it mutually exclusive genetic alterations, or MEGA, MEGA, that usually they don't happen. But to give credit, Dr. Javli from MD Anderson were able to find very rare number of patients that can have more than one alteration, specifically FGFR2 and the IDH1. But it's not necessarily that it will apply that's a commonality per se. If you have that challenge, talk to us. We'd love to hear how you're going to take care of that as well. And Dr. Goyal, back to you, and kind of like more into the FGFR business. would you, if anybody progress, re-biopsy them in real life? You spoke about your data, but would you do another biopsy?
Yeah, we often do both liquid biopsy and solid tumor biopsy. The truth is, the resistance mechanisms are sometimes through FGFR2, and people have kinase domain mutations which are picked up on liquid biopsy. But there are other resistance mechanisms such as MET amplification, EGFR amplification, other new fusions sometimes, where people can develop other alterations that are not well picked up on liquid biopsy. And so it depends on how safe it is for the patient, how urgently they need to start on the next treatment, but we often do baseline repeat biopsies. I'm not doing it, though, to check if the FGFR2 fusion is still there. In my experience, whenever we rebiopsy, in nearly 100% of cases, the FGFR2 fusion is still there.
Fair, fair. We'll wrap on one last question for Dr. Vogel. And aren't you kind of referred to potential second line? Remember, not everyone is going to have a genetic alteration in your sport, or referred to second line systemic therapy being chemotherapy based. And you kind of like refer to some of them. Please tell us a little bit more about the liposomal irinotecan 5-year-old data that came from Korea versus the FOLFOX. Your thoughts?
Not only from Korea, but also from Germany. So, I mean,
Sorry, an error in the translation. Sorry. How would I do that?
For FOLFOX, we have good the ABC06 study with, proof that we add efficacy, that we can prolong survival with FOLFOX compared to best supportive care, active symptom control, which is good. But median overall survival is still extremely short. So the question is, can we use other chemotherapies? And in other GI tumors, we use irinotecan. So the question is, can we use also these irinotecan-based chemotherapies? And we had actually 2 trials, one in Korea, one in Germany, very similar design, where we compared Naliri 5FU versus 5FU alone. In South Korea, we observed a significant benefit in terms of PFS and overall survival, which we unfortunately were not at all able to confirm in the German study. And the side effect profile was a little bit different, which is interesting and which might have also led to the difference in outcome, that the toxicity profile between Asian patients and Caucasian patients is a little bit different in terms of GI toxicity, hematological toxicity. In the German cohort, we had more dose reductions and treatment was stopped. We also had more crossover, so there are a couple of things that are coming together. Overall, do I think, would I not use irinotecan? I still use irinotecan. I'm not really sure whether we need to use nanoliposomal irinotecan, but I still think in fit patients, FOLFIRI is still an option.
Fair enough. Yeah, no, more to come on that. But anyway, we'll come to the end of things. Let's see here. So, oh, good. So this is a message for me. I thought that you were talking. I'll read you the message. They said, Ghassan, this is Carmine, Carmine from the back. The winner of the Amazon card to be announced when the time comes is, now the time is here now, it's actually Layal Mahmasani and Grayson. Layal Mahmasani can see Grayson from PeerView, who will be ready to give, they put him, but I think it's her, the gift card. Congratulations. All right, very good. Well, thanks very much, everybody. And big thanks, number one, for PeerView. I would like to really denote Carmine and also Jessica, both our doctors who really did great work to help us with regard to this program. And of course, big thanks here for Dr. Goyal, Dr. Vogel, and Dr. Harding. It was delightful to thank you all for being here. And if you have anything still hanging or lingering around, we are here to help answer any questions you have left. But thank you very much and have a great evening. Thank you. Well done, guys.